sub-counties. So, okay, at least the 2 sub-counties is okay. You reach the sub-county, no, we are just in 2 parishes each. Then when you reach the 2 parishes, you know the money was not enough. We now decided to choose one village. But the trail which you have up here is that the north is now under you, you're in charge. So if we are drawing a map, we will have a map which is like a joke. And the outcomes will be useless. So just tell us we have money for 2 parishes. From the parish, we are going to check. Big talk doesn't help us. Please, let's align with our institutions and the health system and use existing SOPs. Ladies and gentlemen, mine was just to reinforce the very many beautiful presentations which preceded mine and those which are going to come. So, and I am purely looking at it from the institutional arrangements, the institutional capacity building. So the last slide. Oh, I was waiting for this beautiful one. If there is anything which makes you very Ugandan, you should be able to speak more than 4, greet people in more than 4 languages. Wanyala nabi, awali foto, afoyo matek, webale nyo, webale mno, webale mnoga, alakaranoi, yalamanoi, iete adruma, orapoze chani chani.
Thank you very much, Commissioner, but I think the health inspector. Okay. So thank you very much, Commissioner. You proceed to this. Let me also call the next president when I'm seated here. So Dr. Emily, you will come over and become the chair of this session. In the middle. So you are the one to issue instructions to the people who are going to ask questions and how we shall proceed and give us guidance. Thank you very much. And eventually I will give you also the powers to close this session. Because
thank you very much, Edward. I, of course, officially take over the powers. You can now go and sit. And when we are done here, as he has said, I will officially also close. Our 2 presenters have actually, I think, trickled our mind as we are talking about the workforce we have in the community. And I hope each and every one of us knows we have the formal and the informal. So as people in the community health space, have you also been critically looking at the formal and holding them accountable for what they're supposed to be delivering right in the community? That is for us to think about and see how we are going to ensure we move forward. I know people have very many questions, but I promise the audience this time we are not going to almost sleep here like yesterday. People are even already looking at their watches. Don't worry, it's approximately 5:32. So I hope that by 6 we are done, so that people can go and rest, and tomorrow we are more energized, so that when our PS joins us, we are in energy mode. Yeah? She does not find a very tired community. When I say community, I'm looking at the people who are so much interested in community health, you know. When you have a common interest, you can also be termed as a community. So right here in this room, we are actually a community because we all have the same interest. So this is the method that you are going to use. For starters, I will take 4 questions. 1 from this region, 1 from here, another one from here, then another one from the other side. 4. Then I'll request the others to kindly write your questions on a piece of paper. When you finish writing it, put it up like this. I have quite a number of ushers in the room. They will pick them, bring them, then I'll pass them on to the appropriate presenter. So I think I'll choose the people who would like to ask questions. We shall start with the gentleman on the other side in the corner. So around this area, okay, I will ask the one at the front, this other gentleman. Someone is looking at me. Don't worry, please write your question down and you forward it. You want to save time and ensure that each and everyone's question is actually heard. So those are two gentlemen. Now I want two ladies, gender balance. So this side, any lady who would like, two ladies who would like to ask questions. Dr. Irene, she's there, then there's another one there in the corner. Yes, so those four can raise their questions that our commissioners can start off the question, answering the questions. Then others, please write them down and please write clear. Yesterday we had a scenario where the presenters could not actually read the questions. I know some of us, we are ourselves and we tend to write very fast. As I am writing I am writing it while thinking about the next words. Hence, I try to rush to write the next words I'm thinking. Please relax, rest, relax, write them properly. First ask your neighbor, are they readable? Because I don't want your question to reach here. We cannot read it. And then you say, Dr. Emily did not let my question be answered. I am someone who likes fairness, So I think let's do that. So we shall start from there, then we go to him, then we go to the other two ladies, this other side. Thank you very much.
Thank you so much, Chair. My name is Mark Wesiga. I come from the organization that works with older people called HANU, but I also work with the Palliative Care Association of Uganda. My one question, we had fantastic presentations this afternoon. Thank you, commissioners. Thank you so much. In the morning, during the National Essential Healthcare Package, Dr. Lyachika emphasized geriatric care for tertiary level care for older people. Of course, the package talks about the elderly. The government has continued to use the word elderly, which sometimes people don't like. Now, in Dr. Upentho's communication at critical cadres down there in the community, are we not leaving the older persons out until they come to receive geriatric care? Because she explained, Dr. Lyachika, that it's at the regional referral and then the upper tertiary level institutions. And then still when Dr. Upentho is talking about the critical cadres, and she has given us this very important document, and we hope government will recruit all these people. There's a position for palliative care nurse, assistant nursing officer, palliative care, but the nurse is not among the key examples that Dr. Upentho gives. Could this be the position that could be actually worked on to make sure that the issues of older people at the community are handled? Thank you.
Thank you very much. That question goes to Dr. Upentho or Dr. Druwali, because I see it in the middle. Please clarify who you're directing it to.
It is in the middle, but I think Dr. Upentho can summarize it.
Okay, thank you.
Thank you, Madam Moderator. I think some of the youngest with the older guys. I'm Kasacha Ali from Mayuge district, VHT. People have been talking about the VHTs, but we are not receiving answers from you as VHTs. I don't know whether we are not part of this retreat. Put that aside, even my people in Mayuge, they may even ask me that what are you going to do there? So this is what they have sent me to do. We as the VHTs, we are community workers and we are volunteers. Put aside the issue of the salary, because my colleague has talked about that. At least you find the way how you can support us, because we are all saving the lives of mothers and even children under 5. But now for us, we are referring them to go for antenatal, to deliver from the health facility, but they always ask for help. If time of giving birth comes, they always tell us to provide them with the transport, yet we don't have any. So please, I don't know who is responsible over this, but also you help us maybe with something like a motorcycle as the VHTs. You provide us with the at least smartphones because we are tired of carrying books. We are going to do home visits, so provide us with maybe smartphones at least can be able to send the data. Thank you very much.
Thank you very much. I think that question is for Dr. Pentho. The next question, please.
Thank you, commissioners, for the very insightful presentations that you just shared. Mine goes to Dr. Durali. Looking at the structure that you've clearly highlighted, that addresses the formal structures, looking at the health assistants, health inspectors. It's clear that there's a glaring gap, especially around the health assistants. Yet we know these are the key people who should be able to supervise our lower community health workers. And many times you reach out to districts, they always complain of the wage bill. So what is being done to help districts ensure that they fill these positions so that we have a proper structure that can supervise the informal structure, that's the VHTs. And also, many partners here have supported the skilling, the tooling, like how you elaborated it, but the challenge comes in when the partners leave and there is no sustainability. How can we help the districts to really put the plan for these community health workers so that they're able to have that continuity even after partners exist, so that we don't lose the gains that have been gained during the initial phases? Thank you.
Okay, thank you very much. Then the other question.
Thank you so much, our commissioners, for the elaborate presentations. I'm Spera Twaire, Country Director for BRAC. Mine is not a question per se, but a contribution and a suggestion, and it relates to the area presentation made by Brenda. There was an elaborate presentation on how the work is going to happen up to the community level. And I was intrigued to understand whether there is an elaborate costing of what that looks like to have an effective community health service delivery. What does it take to have an effective, because we look at the community, at the healthcare facility, at the catchment area. Do we have an idea? Is it something we want to interest ourselves in to see if there are partners who are interested in supporting such processes that can easily inform planning and support accordingly?
Okay, thank you very much, our dear participants, for the 4 questions that are going to kickstart as I receive more questions. As they are answering, I will be distributing to the appropriate presenter. This way we shall be able to save time and ensure more questions are answered. So at this point, I will hand over the floor. I'll start with Commissioner Pentho. Dr. Duale has just finished talking. Let him first rest a little bit. We start with Dr. Pentho, and he answers the questions that he has.
Yeah, thank you very much, and I expect very many questions. If you don't ask me, when you get to the community, you will sweat to answer the questions alone. So that time I will be out of stock. We are not an implementer, so we just give no guidance. So listen, I want to start with Mark. Mark is asking about palliative care, and he's talking about geriatric care in older persons. He's thinking that there should have been an assistant nursing officer, palliative care nurse, to take care of our nation at the community level. And of course, in the presentations and the document I've given you, there's nothing that points to palliative care. I still think there is a commissioner here who we brought here for this meeting deliberately, and should be the one to answer why
even when we are fighting for these cadres, we are calling formal cadres to be at our health centers, he allowed people to remove palliative nurse from the structure. You see, we are actually fighting to remove cadres because of the cost. If you see the billions of shillings which must go to pay for these cadres at health centers, that's September 4 and 3. It's a lot of money, and so people are saying, if this goes to public service and then to finance, they will throw away your structure. Nobody is going to approve it. So we are all being very, very careful not to give room for public service to throw away, our structures and establishment. Ideally, this was not what we wanted. We wanted also some cadres which we don't see here. They are very, very many. They were up to health center too. And we are guided, just don't do everything. But start somewhere. That's why we don't see palliative care nurse here. But there's a palliative commissioner here. He's going to answer.
Dr. palliative care is there. My question was, in your examples of who you are going to work with down there, you didn't mention the position is there.
Hey!
Officer palliative care.
You wanted me to mention everything. Okay, it is mentioned now. Okay. Kasaja, I'll get you from my. You see, the story around PhD and Jews, I know you are asking for enumeration, you are asking for support, because of what you are seeing happening with Jews. And this is going to be a very big question for us to tackle in the long run. To start with, not just to hide any story problem, that Jews came in with the mindset of replacing the militaries at the beginning. That was the initial strategy. But I think people fought and said, you cannot remove the militaries. After all these years, all the services you have rendered, it would be not correct. And you did very, very well around COVID time. That's why now the village health team position at the village level got entrenched. Because how you decided to do the community engagement in the community to make sure that people eat jaga, drink those family things to keep alive, and they kept alive. So we said, you will be there. And that's why your position at the village is now not being tampered with. But because we have already started a journey of saying, let's have another cadre, because we are going to phase out health center too. There should be a structure at that parish level. But you also know that our underlying ministries, agriculture, for example, agricultural extension workers, they are also livestock extension workers. I don't know whether what are those extension workers. At this level, it's only us mental health who don't have extension workers. So we were also thinking there should be extension workers so that they can extend services which were meant to be delivered at facility, but now they carry and run with it to lower levels. And that's how we now think, going forward, the strategy for CHOOS and the strategy for village health teams should be related. A consultant has been procured, I think. They are busy looking at how do we rewrite this strategy so that all these complaints you are making can be taken care of. But the only challenge is, and I wish Public Service was here to guide, that for as long as in our constitution you are called a volunteer, you can never be paid salary. Because our constitution does not allow paying salary to volunteers. But together we can think through how would we motivate a village team, how would we motivate a community health extension workers. Because that's the reason why we are still calling them informal. But the moment you become formal, you're entitled to salary. That's why we started group, formal and informal. Okay? And what we are seeing being given to community extension workers and just provide a form of motorcycles, bicycles. There's a partner here on the ground saying if what they are doing is really sustainable. The level of providing motorcycles, I don't know whether we will succeed. That is my vision about how we are taking the community health services that level. Those things, given our economy, I don't think we can sustain it. But your motivation is important. Okay? It can be in the kind, but can also be in monetary. Depending on how, together with the partners, we think through. Okay? Yes. Of course, in some places we are already giving smartphones to the villages to help in data collection, data management, and enabling you to do your work well. They are giving you bulbs, they are giving you pens, they are giving you other things. On top of the supplies which are medical and non-medical to support your work. That's the challenge. Okay? But to see through various comments of have you costed how much it takes to implement this service package we are talking about? Well, the entire community strategy was costed as a strategy. But you know the strategy is a high level. Okay? Now, when you start going down and running it, you need to break down the cost. Now the cost for this strategy, the cost for this, and if you invest in this, okay, this is the return on investment. Okay? That was the thinking. And so even when they had posted that strategy, the thought came through that now why an investment case? The investment case is now being discussed. It is under approval processes. Okay? Yes. And when it comes through, we shall also show you that if you invest in this area of community health, these are the returns on investment. But like Dr. Duale said, Ministry of Health, like any other ministries of government in the country, the reason why they mark time when it comes to implementing primary care or community intervention is not the main subject. It's the most costly, and you don't see the return of investment immediately. You got to wait for generations and years. Now, how to run in a political mode? People want to see, send you to parliament and give you this 5 years. What are you going to bring forth? You cannot invest in primary care of community health, which will give you returns after 30 years. You will no longer be a member of parliament, you will no longer be a president, okay? You want quick fix. This way you go ahead and promise that I will give you a loan which passes over this hotel when you make it possible. You get a point. So you go ahead and look for quick fix. So health center here, then maybe an ambulance, even if ambulance is just a box, okay? So that people can see. When you come back and say, if you now send me to parliament again, the next time, and they come with a helicopter from my campus in a which area, we take your patient to ambulance. I said, thank you. These are the questions I got.
And colleagues, this is a kind request. When you're writing your question, please let it be in context with what we've been discussing. Are we together? So I don't want someone now starting to ask us in this current discussions why some people earn more than the others and what we are going to do about it. That's one of the questions I have here. Someone asking me why a driver earns less money and drives people who earn 5 to 10 million. So please ask questions in context with what has been presented here and in context to the general theme of this retreat, which is accelerating towards an integrated community health agenda. If we are not careful, we shall even start discussing things that are not related to us, to the purpose as to why we are here, and we end up not discussing the core things that we came to discuss and see how to move forward. So Dr. Fentz, I've handed you over like 3 other questions. I think you looked through them. They were more about CHUs and VHTs. I think you've given a comprehensive answer. So the questions, I hope that people have gotten answers to their questions. So at this point, I will ask Dr. Duale to answer the ones he has so far received, as I give Dr. Bento some others, and he organizes himself on what to tell the audience.
I didn't know you were very attentive. The questions which are coming speak to that. Just to add on geriatric care is a government priority. There is a minister for the elderly. He secured a cabinet resolution to ensure that we do specialist training for taking care of the elderly. And he followed it up, and I followed it with Makerere because the instruction was specific that Makerere should start that training. But the discussions are ongoing. What we also got to realize is geriatrics training is a multidisciplinary training. So it's not something linear. So the institutional arrangements to produce that cadre, it's more complex than anticipated. Resources are being mobilized in that direction. So the package for the lower level, at the community level, will be to identify an elderly person in need of care, do the basics, and refer. The referral system should not be forgotten. Now, through community health interventions, we are strengthening that arm. Now, the health assistance gap, the gap there, I also noticed it. My feeling is that I must have landed my hands on the old version. The number of staff needed to fill those positions is very high, and probably this will define the new areas for intervention to anchor community health. If you don't have the professionals, then the volunteers and the community health extension workers can do it that much. But as I said, those people cannot function on autopilot. They need to be backstopped. And these structures cannot be left the way they are. So thank you for bringing that up. So the training by partners can only be sustained if you are training people who are filling gaps in an established position. If you are training, see the difference. If you train a health assistant to do what you are doing at the community level, even when you go, since he's salaried, he will remain around. The knowledge, the skills will remain available and longer. But if you circumvent that structure and train lower down, the day you close that project, then investment in training and knowledge will become individual asset as opposed to a public asset. So anchor your investments on existing structures. As a department, we have, besides looking for institutional capacity, knowledge management, institutional capacity building on one arm, on training, there are areas of focus for us. Number one, specialist training, super specialist training. Number two, in-service training of healthcare workers in the essential healthcare package. I keep emphasizing this. If you start practicing one side of the package, with the time you're going to become irrelevant. A clinical officer who gets stuck on HIV and nothing else, you lose the other skills. But he should maintain, a professional should maintain his skills to handle both HIV and other diseases. In any case, patients don't come to you with a diagnosis. You also require some clinical skills to diagnose HIV, to diagnose TB, because they will come like something else, they will come as fever. So clinical skills must be kept at the edge. So in-service training is one of our key areas. The last part is leadership training. Health workers, health centers, they are holding lots and lots, millions of shillings. Forget about the allowances, which you say, no, it's only 5 million. No. What about the value of medicines? Those are a lot of resources. But to manage them, you require leadership. You're managing people. Their value, look at it. So you need to manage them to increase the productivity. So their leadership training skills, the skills which we need to impart. So those are the three major areas of training. There are many people who are acting in their positions. The bottlenecks we have are mainly wage and the lack of will to fill those positions. I don't want to say more. But if you have the position on structure, you know, the last structure we have done, we have now secured permission to get more people into service. That's a big milestone. Now, as wage increases, you can now recruit. Otherwise, if you don't have it on the structure, you cannot think of recruiting anyhow. The submissions you have made to Health Service Commission to fill positions for community health, recruitment, as you know, is a process, and those stages are controlled. So I think if you're from a regional referral hospital, take interest and follow this. I think this is an administrative matter. There is no policy to slow it or to deny recruiting for you. Have you gone to the Service Commission to see what those people go through? Do you know now online application has made it better? A position for enrolled nurse, this room is not enough for the applications. Up to the ceiling. It is worse if it is for mortuary attendant, if it is for... So please, just sympathize with the process. But I think where we have reached, it is workload, which is sitting on the commission, and where we do not have money to fill the new structure, I think that is for my colleague, Dr. Sarah, but I think we have a place where to start. When the wage is not enough to fill this new structure, our new effort will be towards advocacy, to see that the more money is available. And this is a long-term to medium-term to long-term issue. This one will drive. There was a restriction, there was a bottleneck in the recruitment process because of approvals from public service and so on. I think that has been undone now. So you just need to play by the rules. Don't get discouraged by by those processes. You know, government is a bureaucracy. Understand that it is governed by rules, and if the rules are not there, what you get is chaos. So we cannot operate as an enterprise or as an NGO which is smaller. But then, do you know how slow processes are? For example, in the UN, they are very slow. Big things move slowly. Government is big, it also moves slowly. Finally, the community health structures, for you to get the best on it, at the operational level, even at the strategic level, collaborations are a must. You need to harvest the collaboration at your technical planning committee at the district level, and at the national level. You can see why we're here. We're trying to make a case for working together. It's only a pity, I don't know whether agriculture is here, education is here, public service is here, and so on. At this level, we need that kind of collaboration and common understanding. If we do not have it in that way, Office of the Prime Minister is here. And that's the linchpin. So when you have the quarter pin, why are you looking for the pedal? So the Prime Minister's office has the obligation to coordinate the other actors who will help us strengthen the community health interventions. Because health promotional interventions are about determinants of health. We can only provide advisory and take advantage of platforms and do health education. When it comes to enforcement, that's another business. So, ladies and gentlemen, thank you for your questions. I think I've tried to answer.
Yes, thank you very much, Commissioner, for answering the questions. And colleagues, when we are asking questions, I hope we are paying attention to what the presenters are presenting to us. Like one of the questions here that he had, in yesterday's presentation, Dr. Kamba mentioned some of the reasons as to why positions are unfilled. I remember that presentation. But I'm surprised when members are now asking the same question that was answered in the presentation yesterday. I'm the kind of person who likes, if I'm to ask a question, then I should pay 100% attention, so that I don't ask a question that will make members, colleagues in the room wonder whether I was actually paying attention. Are we together? So let us pay attention so that we don't ask questions of things that were presented yesterday and we are asking them now. There's this question that the ICC component is a very important intervention at community level. The stockouts of RDTs for the last 3 months has hindered the work of PHTs. What is being done to handle the stockouts, and what is the government planning to do? We shall engage the ICCM coordinator at the Ministry of Health, and we get to the bottom as to why we are having stockouts. They might not even be aware, because maybe the line of communication is broken, or maybe they might be aware and they are working on it. So we shall get in touch with the ICCM coordinator and we ensure it is addressed. So the person who wrote this, actually I think you'll see me, so that you let me know which district that is, because I don't think it must be the whole Uganda. Thank you. So Dr. Offent, I think you received a few more questions. So I'll let you answer those few, and then we call it a day.
Okay, thank you. And again, I want to say thank you, because I said if you don't ask me, you will sweat. This time the man was saying that if you don't treat the people very well, they will believe in the talk line. I'm giving you these answers. Number one question is saying about peer-led approach. In the presentation since yesterday, I'm only hearing BHTs in the structure. How are you planning for the KPs, the PPs, the peers? This group is supported by civil society. How we serve when the NGO stop supporting peers? Okay? Now, if the NGOs stop, okay, or they die, they will die with the peers. Because what the ministry is saying, Our structure as ministry is clear. From the village we have the village teams. From the parish we have the Jews. Then at health center 3 we listed there. Health center 4 we listed there. Now that is government structures which are known. And the government doesn't die. Okay? You get the point. Government doesn't die. But NGOs will die one day or another. That's why we are saying, even in this multi-sectoral approach, we will use the partners who are there. We don't say we create new ones. If they come as new ones, we start from them. We show you the whole of society approach. In the whole of society approach, we say there will be also other community volunteers. These peers, whatever other name you are going to give them, they are part of the community workforce, which we call the others, which we said we shall work with them. And we know they will be supported by whoever created them. Okay? Including the plan that Joale was making in this last submission, that let's work with the establishment which is there, okay, and the institutions which are there, and the existing SOPs. You make a point. Because if you come as a partner and you come with your own peers, with your own SOPs, when you die with it. Now, here they say, please improve care for older persons in the training of Jews and HTs. We have given you a comprehensive service package, and we are saying this service package, people must be mentored on it, must be trained on it, must get to know how to implement the service package. Okay? So whoever is going to train and trace whichever cadre must make sure that these are the things people need to know. If that's the thing we want to take to those beneficiaries. Now, about the informal community workers, we have the Jews at the parish, while the village teams at the village level, supported by NGOs. The question is, how will these Jews supported by NGOs relate with VNGs, and how will they fit into the mainstream system? Now, again, I'm saying the mainstream system and the village health team.